Hey everyone, and welcome back. Today, we're diving into something that feels a little bit like magic, but it's all science: regional anesthesia. It's this incredible field where precision is everything.
I mean, just think about it for a second. You could be having surgery on your arm, wide awake, maybe even chatting with the nurses, but you feel absolutely nothing. Zero pain. It sounds like something from a sci-fi movie, right? But it happens every single day. So, how is that even possible?
Well, that's the genius of regional anesthesia. The core idea is simple. We make one specific part of your body numb. See, instead of putting your entire brain to sleep, we just intercept the pain signals before they can even get there. It's like putting up a roadblock on the nerve's highway.
So, here's what we're going to cover. We'll look at how this is different from being put to sleep. We'll get into the nitty-gritty science of how it works, take a quick tour of the common techniques, and then, of course, we'll talk about safety.
All right, let's jump right in. First, we have to get this one key idea straight. This is not about being put under. Yeah, with general anesthesia, you're totally unconscious. But regional anesthesia, it's all about precision. Think of it like a sniper rifle versus a cannon. We're not trying to take out the whole system. We're aiming for a very specific set of nerves to get a very specific result. Pain control in just one area, all while you stay perfectly awake and aware. Okay, so how on earth does this actually work? I mean, on a microscopic level. Let's zoom right in and look at the science of what makes you numb. It's actually a pretty elegant four-step process. You see, your nerves are basically tiny electrical highways. They send pain signals using a flow of sodium ions that rush through these little tiny gates. So when a local anesthetic is injected, its molecules literally just plug the gate. And if the gate's blocked, sodium can't get through, the electrical signal can't fire, and that pain message is stopped dead. Simple as that. Now, the drugs that do this come in two main flavors: esters and amides. And here's the key difference, the thing you really need to know. It's all about how your body gets rid of them. Esters, they get broken down super fast, right in your bloodstream. But amides, like lidocaine, which you've probably heard of, they have to go all the way to your liver to get processed. And that difference is a huge deal when deciding which drug is the right one for the job. Okay, this is where it gets really clever. We can look at three key properties of a drug and predict exactly how it's going to act. First, its pKa tells us how fast it will start working. Then, its lipid solubility, basically how well it dissolves in fat, tells us its potency, how strong it is. And finally, how well it sticks to proteins tells us the duration, how long that numbness is going to last. But that's just the drug itself, right? The drug doesn't just sit there, it eventually gets absorbed into your bloodstream, and where you inject it makes a massive difference in how fast that happens. So how do doctors remember which spots are the fastest and which are the slowest? Well, they use a mnemonic that is, let's just say it's memorable. Yeah, this very quirky phrase helps them remember the exact order of absorption, which, as you can imagine, is absolutely critical for keeping patients safe. So what does that quirky phrase actually mean? It gives us this list, from fastest absorption to slowest. It starts with intravenous, right into a vein, then tracheal, intercostal, that's between the ribs, and goes all the way down to subcutaneous, which is just under the skin. And this isn't just trivia, Knowing this order lets your anesthesiologist perfectly dial in the dose to make sure it's effective, but never toxic. All right, enough with the micro-level stuff. Let's zoom back out and take a quick tour of how all this science gets put into practice every day. Okay, so let's say you're going in for shoulder surgery. Your anesthesiologist might do something called an interscalene block. They inject the medicine right near this big bundle of nerves in your neck, the brachial plexus, and poof, your entire arm and shoulder go completely numb.
But here's the catch, and it's a huge one. 100% of the time, every single time, that block also numbs the phrenic nerve. That's the nerve that controls half of your diaphragm, your main breathing muscle. Now, for most of us, not a big deal. The other half just picks up the slack. But what if you have serious lung problems already? Well, then this block is totally off the table. It's a perfect example of the kind of precision and trade-offs we're talking about.
And it's not just for shoulders, of course. For hand surgery, you might get an axillary block in the armpit. There's even a clever one called a beer block for short arm procedures. Down in the leg, a femoral block is great for knee surgery. And then you have the ankle block, which is just incredible. It takes 5 separate, precise injections to numb up the foot. And now for the grand finale of our tour, we're going right to the central command, the spine. This is neuroaxial anesthesia. the world of epidurals and spinals, which can numb up huge parts of the body for everything from childbirth to major joint replacements. And there's this really fascinating thing that happens here called differential blockade. You see, your nerves aren't all the same size. The drug blocks the smallest ones first, the ones that control blood pressure. Then it gets the ones for pain and temperature. After that, touch goes away. And the very last things to go numb are your biggest, thickest nerves, the ones that control your muscles. It happens in this exact predictable order, every time. Okay, so this is all incredibly powerful stuff. And with great power comes the need to talk about safety, because these are amazing tools, but you have to know how to manage the risks. One of the biggest risks is if too much anesthetic gets into your bloodstream, especially for your heart. And let me tell you, not all these drugs are the same. Bupivacaine is an excellent, long-lasting pain reliever, but it is way more toxic to the heart than the others. It's something that has to be used with a ton of respect and caution.
You've probably heard of the spinal headache, right? It's officially called a post-dural puncture headache, and it's caused by a tiny leak of spinal fluid. The classic sign? It's all about your posture. The headache gets way worse when you sit or stand up, and it gets a lot better when you lie down flat. It's a dead giveaway.
Now, there are a few other risks. We mentioned toxicity, which is called LAST. Some blocks near the chest have a small risk of a collapsed lung, and in very, very rare cases, there can be some nerve irritation. But the key takeaway here isn't to be scared. It's to know that anesthesiologists are trained to prevent, spot, and immediately manage all of these things. So when you step back and look at it all, from blocking one tiny nerve in an ankle to making the entire lower body numb, regional anesthesia is just this incredible blend of anatomy and pharmacology. It has absolutely revolutionized surgery, making it safer, with better pain control and much faster recovery for millions of people. And that just leaves us with one final thought, doesn't it? We've gotten so good at these temporary roadblocks for pain. Now that we can target sensation with such amazing precision, what's next? What's the next frontier for how we manage what people feel? That's all for this explainer.